questions that you want to pose to the panelists in the
We are
chat
live
box.
now.
Yeah. Okay. So good evening, everyone, and another episode of Surfing the Anterior segment. And this is the core team, of course. And today we'll be having episode 7 of Surfing the Anterior segment. And the topic is trauma in oculoplastics. So we have some expert panel members who we'll be introducing. And moderating with me is Dr. Gunjan. And we have two young presenters as well who will be giving us some interesting case presentations. So, Dr. Gunjan is currently based in Chhattisgarh. She's a strabismus, oculoplasty, and neuroopthal consultant. She has completed at the RP Center, and she has several publications to her name, which is very impressive. She also has some prestigious awards to her name, such as the International Ophthalmologist Award by the AAO and the Best Outgoing Senior Resident Award from RPC Ames. Over to you, Gunjan.
Yeah, thank you, Dr. Rithuja, for that introduction. And it gives me immense pleasure to introduce to you all my co-moderator today, that is Dr. Rithuja Thomas Grover. She is an alumnus of St. John's Medical College and holds a university rank in ophthalmology. She has presented several papers at national and international levels and is the recipient of several prestigious awards. She has completed her post-graduation and fellowship in oculoplastics and oncology from Narayan Nethralaya, Bangalore, and currently is practicing as a consultant oculoplastic surgeon at Vision Eye Center, Delhi.
Right. Thanks, Gunjan. We are very pleased to welcome Dr. Saurabh Kamal, very experienced oculoplastic surgeon, to lend us a bit of his expertise today. So he completed his training at LV Prasad in Hyderabad, and his post-graduation from Maulana Azad. He has several publications and has presented in several conferences, and is also the associate editor of the BMC Oculoplastics and Trauma. So welcome, Dr. Saurabh, and very grateful to have you with us today.
So it's my pleasure to introduce to you the other expert today who is there with us. This is Dr. Sonam. She has completed her basic medical education from Karnataka and her master's in ophthalmology from Telangana. She has done her research fellowship as well as clinical fellowship from Shankar Nethralaya, Chennai in orbit oculoplasty, aesthetic and reconstructive services, and is currently an associate consultant at the same institute. Her special interest includes ocular trauma or vital infections, management of thyroid eye disease, aesthetics, and socket reconstruction. She has a couple of publications to her name and has written a chapter on ptosis. Her video recently it received the Best Video Award in OPAI, as well as in the American Society of Ocular Trauma 2021. She received the Best Paper Award. Welcome to you, Dr. Sonam.
Thank you. Thank you so much for your kind words, Gunjan. It's my pleasure to be a part of this.
Thank you, ma'am.
So one of our young presenters, she's a fellow currently at LV Prasad in Hyderabad, and she has also presented several papers and has also been the first runner-up for the Gangadhar Sundar Award at OPAI this year. So that's a very prestigious award as well. So we look forward to hearing from Dr.
So now our next presenter today is Dr. Priyanka. She has completed her primary medical education from Rajiv Gandhi University, Bangalore, and her postgraduate training from Netradham Super Speciality Eye Hospital, Bangalore. Following this, with a keen interest in oculoplasty, she pursued her 2-year long-term fellowship in ophthalmic plastic and ocular oncology services from LVPI and has presented in various forums and is involved actively in the academic activities. Her areas of interest include orbit, ophthalmic plastic surgery, and dicryology. She is presently a consultant in oculoplasty services. We are looking forward to your case today, Dr. Priyanka, and thank you for joining in.
Right.
Thank you.
Let's have Dr. Richa with her presentation now.
Yeah. Yeah, I hope my screen was all visible and I'm audible. Yes? Dr. Rutuja?
Yes, your screen is visible.
Oh,
Good
yeah.
to go.
thanks. Yeah, thanks. So, hello everyone. Thank you for giving me this wonderful opportunity to present in this forum today. I would be presenting the cry of the third eye, tackling an ectopic lacrimal fistula post-trauma. I have no financial disclosures to make. This 29-year-old male presented to us with watering in the right eye since 4 months and a discharging wound over the nose that was not healing. He had suffered facial trauma 4 months back, was diagnosed with a naso-orbitoethmoidal fracture, and had undergone open reduction and internal fixation elsewhere as per the notes. On our examination, there was a depressed nasal bridge, acquired telecanthus and epicanthal fold on the right, and right madarosis that was seen. On a closer look, there was an inflamed discharging fistula along with perifistular scarring present over the glabella. The anterior and posterior segment exam in both the eyes was within normal limits. On performing rhoplast, that is regurgitation over the sac, regurgitation on pressure over the sac, there was a regurgitation that was seen through the fistula, and on performing irrigation, there was regurgitation through the opposite punctum as well as the fistula that was seen from the right eye, and left eye was freely patent. With this, we came to the clinical diagnosis of secondary acquired lacrimal drainage obstruction post-trauma with ectopic lacrimal fistula. Now, he already had imaging post-fracture repair, which was suggestive of an unaddressed nasal bone fracture, plated maxillary fractures, and a thickened bone formation near the right lacrimal sac. Now, prior to planning any surgery, we wanted to perform a CTDCG, which revealed a large dilated sac and a sequestered fundus in communication with the fistula. All this was present close to the base of the skull, and there were no plates or screws present near the sac area. So with this, we planned for a right eye external laparoscostomy with circumostial MMC and bicanalicular stenting, along with a combined external and endoscopy-guided fistulectomy.
A curvilinear incision was taken over the lacrimal sac area to expose the sac. The anatomy was distorted with a large dilated sac, overlying scar tissue, callus formation, and a large fistula superiorly. 2 probes were placed from the external fistula and the upper punctum to identify the internal communication with the sac. The fistula was noted to arise from the narrow diverticule over the fundus. The communication of the fistula and the sac was severed near its entry into the bony canal. Sac flaps were fashioned to view the internal common opening and the fistulous opening, and they were noted to be far apart. Overhanging bony edges were punched using rongeurs to expose the internal tract. This is the view of the internal tract that is exposed. A probe was then inserted through the external portion and it was identified and excised. The internal portion was excised in toto to the extent possible. Powered osteotomy using a diamond burr for bone drilling was carried out to remove the thick callus and expose the nasal mucosa. The tract was then curetted from the internal and external aspect. And this was the appearance after mucosal clearance. Endocautery was used with a fulguration tip to obliterate the passage completely. Inspection from the external wound confirms closure. Apart from circumosteal mitomycin C injection, the rest of the DCR surgery was carried out as a routine that included the placement of a bicanalicula stent and suturing of the anterior mucosal flaps. The fistulous wound was closed using a local advancement flap using interrupted 6-ovitral sutures.
So post-operatively at 1 month, the patient had well-healed wounds without any discharge and irrigation was freely patent. So the take clinic message from this presentation includes that we should anticipate all the intraoperative challenges in post-trauma, especially with respect to ectopic fistulas. Always a careful pre-operative clinical and CTDCG assessment is important. Every component of the pathology needs to be addressed to achieve a successful outcome. And endoscopy guidance for better delineation of the distorted anatomy and direct visualization of the entire fistula sac is useful. Thank you.
Thank you, Richa. That was very well documented and very, very well presented. I'd like to invite Dr. Saurabh for any questions he has for you or any comments, and then we'll go on to discuss your case.
Yeah, very nice case, Richa. Good to see the lacrimal work here being done by Dr. Javed. I think a very well approached case and very well planned. Just from the CT, I want to ask about the CTDCG. The film, I think, can you put on the screen?
Yeah, sure.
The there in your presentation.
Yeah, just a minute.
So I just had a few. So what would be your differential like for such two, bisected? One you already said that ectopic lacrimal fundus. It was ectopic lacrimal fundus. So what could be the other differentials from such CTDCG images or the findings? Yeah, this one,
Yeah, it's visible.
So this was like just for the audience, CTDCG is basically performed when you put the contrast either through the syringing irrigation or through as a drops, and then perform the normal CT scan, and it images the lacrimal system, the sac, basically the sac, and in cases of trauma. So Richa, can you just tell the findings here, and what could be the other differential? My basic question is, what could be the other differentials?
So it could actually be sequestered dye sometimes if it's gone into the wrong plane while syringing. That would be my
yes, could be that. So this was done through the lower punctum.
Yeah, lower punctum.
I think it's through the lower punctum. Okay. And this was the imaging must be, I think, after 5 to 10 minutes of the irrigation.
Yes,
of the,
yes.
So what could be, you are not, could be the other differential. One is the lacrimal. So what I want to ask is basically it's a lacrimal sac itself, which is bisected. So how could you explain these two reservoirs of in the lacrimal sac? So what happened basically during the trauma?
Yeah. So there was an unaddressed nasal fracture, right? So one of the fragments could have actually caused trauma to the sac, causing this appearance, and then healing post the trauma because the nasal fracture wasn't addressed.
So was it combination of sharp and blunt injury both? Because obviously we know the blunt
injury. It was a road traffic accident, so I'm assuming it was a high velocity trauma.
Yeah. Okay.
So,
okay. Yeah, this could be one of the trauma itself, which has some maybe a sharp object, penetrating object, has also severed the lacrimal sac into two, divided the fundus and the body into the two, and then it has carried some tissue maybe to the to explain the fistula happening to the base of the root of the nose. So that's why the fistula maybe occur because of the sum of the epithelium. And this is a 4 months old case, no? After the injury.
Yeah.
When it
Yeah.
So
So he actually had an external, like if you can see my pointer, he had an external scar here, right? So probably that is secondary to the trauma. So this part was also a part of it, and maybe the sac tissue and this epithelium got connected somehow due to the fracture, and that's how this fistula came about.
This could be one pathophysiology, the trauma itself, and second could be any like foreign body, which may have entered the fold, the medial canthus region, and maybe we are not aware that during the primary wound repair or whatever the previous surgery for fixation of bone, that foreign body may have actually carried it, be some tissue of the sac, from the medial and the lateral portion, and buried it through the root of the nose, and it may be just pulled it out. So very interesting, I think very interesting case to explain though the pathophysiology. What could be the other differential of these two?
A diverticulum.
Yes, diverticulum. Yeah. He may be having diverticulum. That is true. That was severed off. And other differential could be because of some mucosa being injured from the ethmoid, or some this which has formed an abnormal communication with the lacrimal sac. So maybe some ethmoid, you can see. What I can think of is localized ethmoidocele or frontocele.
Okay.
So these differentials, I think we should kept in mind, apart from the lacrimal sac, the mechanism of injury, what give rise to this finding. I think it's a very interesting finding, both the migrated sac and the fistula, and also the pathophysiology, just to know from the, explain these findings. Yeah, good. I think very good documentation. So second is like, how did you proceed? So the osteotomy was primarily done through the external approach. Can you just clarify? Because I think that part was from external point was missing in the video.
Yeah, the osteotomy was done from the external approach.
Then
mainly by using the bone drill, because that bone was very hard. There was like a callus over there.
So it's very important. While doing osteotomy in such cases, very important, because may have very fragile fragments, and if you can just pull, you can easily fracture the root of the middle turbinate, and then fracture the skull base and cause a CSF leak. So that is very important. And mostly during such traumatic cases, there is a lot of also oozing and bleeding, because the tissues are scarred and fibrosed, and you are opening these tissues, and CSF may be difficult to identify. But we know that how to identify the CSF. One approach is obviously but second one is the use of the endoscope, because if you insert the endoscope primarily in the nose, you can see the clear fluid within the blood coming from the root of the nose. CSF is very important. CSF leak is especially very important in these cases. Okay, so rest is fine. I think we can discuss maybe other panelists, and we can have discussion.
Yeah. So Dr. Sonam, what if we don't have a CTDCG, or the patient can't get a CTDCG? Do you think it's okay to just sort of see the connection of the fistula intraoperatively and then go from there?
Of course, CTDCG will give you a preoperative idea and will help you prep up better for the case. So I think it's a mandatory norm in traumatic NLDOs to actually do a CTDCG. However, sometimes if like in a lot of places where high volume practices are there, patients cannot afford that, then probably what we can do is we inject the trypan blue dye, which is readily available. Okay, and that, or a fluorescent stain. With that, if you inject, also you can actually trace the connection which is there, because what you saw very well documented, Richard, externally you could see the fistula right there, And if you actually do the irrigation and you open it intraop, you'll be able to see that the entire sac would have been well lined with the trypan blue dye. But just a word of caution, always dilute your trypan blue dye. Do not inject it in a very concentrated fashion. Otherwise, your rest of the tissues around about it would also get stained. So that is one thing that can be done, but we don't recommend that in general unless there's no other option. So that is one. And so any other option when we don't have the bone drill, you can always use your chisel and hammer if you have that, if the bone is very hard. You have to be very cautious. Like Dr. Saurav said, in cases of trauma, you have a very low lying skull base. So we can always induce a CSF leak in these patients. So be wary of that. That's all.
And any cases, if any of you all have encountered where it's iatrogenic without any fistula, of course, that there's an iatrogenic sort of thing where there are plates, screws in place, and you have to sort of remove everything. So what is your experience with that?
So we recently published an article on Indo, the iatrogenic nasal lacrimal duct obstruction. So we've had a couple of cases with that, and it depends on. So what we do is, yes, you will have to remove the screws and the plates, and then you will have to go ahead and do your DCR in seeing eyes. But if you have a patient who has a very bad thicycle globe or an anophthalmic socket for whatever reason, then you can just get away by even doing a DCT for that patient and then later on manage secondarily, because these kind of traumas generally for anophthalmic socket, I feel it's okay to get away with the DCT, and then probably if the patient is very symptomatic with epiphora or something, then plan management for that in the second sitting. So, but yes, young patients who are very particular, you might have to go ahead and do a DCR. Dr. Saurabh, any thoughts? You would like to add anything on that?
I think you're on mute.
Saurabh, you are on mute.
Yeah, now can you hear me? So just in this case, I think it was bilateral symmetrical, but the telecanthus repair, if the patient, cosmetic wise is concerned, is very difficult in these cases. So this was obviously the bilateral, so patient was not that keen, but otherwise also so how do you proceed? Any thoughts, Richa? Like especially the DCR, if you're doing, and we prefer external DCR in traumatic cases. And how are the approaches? What are the approaches for medial canthus reconstruction, especially the telecanthus? Yeah, because so any options that you can just give us?
A YV-plasty. Yeah,
that will take care of the epicanthus. So there are two, like in your case, there were two findings. One is the epicanthus. Epicanthus is basically which is a fold of the extra skin. So that is like YV or CU, or you can have mustardase, you can have Z-plasty, all those options. So telecanthus,
You're talking about the
telecanthus. So that is like
so the
your medial canthal tendon is severed, and that has caused the movement of
So we need to actually examine intraoperatively what is the status of the corresponding portion of the nasal bone, and if there is any stability there, because considering that the medial canthus is also torn, it is a complicated naso-orbitoethmoidal fracture involving the canthus. So finding a piece of bone that is stable over there, and then maybe either drilling through it or attaching it, or even I don't know how often we do it now, but transnasal wiring is an option. I don't know.
Especially I want to highlight because we create a large ostium, huge ostium, especially the superiorly, because of the common canalicula's internal common opening line. So that's what is the point I just wanted to highlight. When you do such good osteotomy, obviously you want to do large osteotomy in these cases because they can cause completely closure, and but then you land up in difficult repair of this telecanthus, especially in the unilateral, because there is no structure so fix it to this. So one thing is in such cases you can have a screw one screw, you can just 1.5 screw of, which comes for you use fracture repair plates. You can drill that in the nasal bone, or as you said, if you find some fixed bone, and that screw you just keep little bit out, pointing, and connect that medial canthus tendon, whatever left there, or medial canthus tissue, to that screw through some maybe non-absorbable suture like 40 or 60 prolene. Or second thing, yeah, more difficult will be the transnasal wiring, but definitely the transnasal wiring will be indicated if you have severe fractures like of the NOE, which lead to disruption of all the ethmoids. So there will be no other options. Yeah. So that is when the medial canthus reconstruction is very difficult in traumatic saldo if it is associated, because it will deal with both the conditions, both the DCR ostium and then the telecanthus repair.
We recently actually did a case where we found a small piece of bone, but it was quite deep. So we ended up actually just drilling a single hole in it. And then we took a non-absorbable proline through it and into the intact medial
A loop
canthus
around that.
laterally. Yeah.
Many things are depending on intraoperative findings. It's just whatever left with you, you have to deal with that.
Yeah.
A mini biplate also is a very nice option. You can just use it and correctly just push it down, like how Dr. Saurabh said. You can just loop it around. You can just plate it, and then leave one screw loose, and then you can just loop your MCT if you find. But another very important point here is in bad NOEs, you actually have to differentiate between a pseudo telecanthus and a true telecanthus, because what happens with NOE fracture, sometimes it's quite symmetrical on both the sides. So all you have to do is you just have to augment the dorsum of the nose, and the patient will actually look much better. We don't have to really go in and do too much medial canthus correction in that case. So what we do is we just do a modified Turkish delight technique, and we just augment the dorsum as well. And with that, if you see a lot of telecanthus also, so that is another interesting point that we can, look into pseudo telecanthus versus true telecanthus. Yeah, that's.
I think many few of us are doing anyways endoscopic DCR, especially if you like these trauma cases. These are very difficult. I myself have burnt fingers. Like surgery took me 3.5 hours, and actually I have to then later on, it was like just after my fellowship when I came in a practice, I had one Saldo, like similar case Balto. So he was having acute attacks, so recurrent attacks, and I was very enthusiastic and wanted to do the endoscopic DCR for him, that I will do this. So, but in these cases, it's very difficult endoscopic DCR. I think if you better always have a combined approach, external, always explain to the patient that it will be primarily an external, and endoscopy will go along because it will definitely help in, making many things clear. So primarily approach should not be endoscopic, because I think is very difficult unless the anatomy is, very little disturbed, or the fractures are little just, you can deal with them easily.
Right. If there's nothing further, I'll just ask Dr. Gunjan to proceed.
So that was a very nice discussion about the post-traumatic NLDO and its management. And now I would like to invite our next speaker, Dr. Priyanka, for her case titled Pie on the Floor.
Yeah, thank you, Dr. Gunjan. Let me just share the screen. So I'm audible and the slides are visible, right?
Yeah.
Okay, so at the outset, I would like to thank the organizers and the team YOSI for this opportunity. So in this short presentation, I would like to take you through an interesting case. So informed consent for photographs and videos have been taken. There was a middle-aged gentleman who presented to our emergency with this clinical picture and a very vague history of self-fall while taking a walk at night, apparently, and he had sustained injury primarily to the left side of the face. So this was a case that we had seen in the emergency, and the clinical photograph to the left shows the actual way he was wheeled into our emergency, and on the right, after we had cleaned up the entire wound with betadine, that was how it appeared. So there was a laceration that was extending along the tear trough onto the left temple area. And at this point, he seemed to be a little bit in a slight altered sensorium. And that is why we sought a neurosurgical consent, and of course, an orbital imaging was ordered. And this was the picture that we took while he was on the bed, actually. And the ocular examination was primarily done on torchlight. And the right eye was unremarkable, you can see. And in the left eye, on forceful retraction of the upper lid, you're able to make out the ocular surface. But the upper, it was tense globe with upper and lower eyelid edema. And there was conjunctival chemosis and congestion. And we just instilled fluorescein to assess if there was any epithelial defect, and that was not present. And as you can see on the higher magnification image to the bottom right, there was a pupil that was mid-dilated. So there was a relative afferent pupillary defect. And also on palpation, the lower eyelid seemed to be a little tense. So with this background of an altered sensorium and trauma history, obviously our first thing to do was to order for orbital imaging, brain as well as the orbit, as well as seek a neurological consent, a consult. So at this point, he sought a neurosurgical consent, and he reviewed back with his orbital imaging. And here it is a photo collage and of a very orbital body, which was noted to be lying on the floor of the orbit. So in the collage to the top left, that is which is labeled as A, it is a 3D reconstruct image, which is demonstrating the triangular foreign body, which is lying on the floor of the left orbit, as we can see. And this is a higher magnification demonstrating the dimensions, mostly on a clearer view here on the image of labeled B. And in C, it is a computed tomography of the orbit with the axial cut that is demonstrating the extent of the orbital foreign body on the floor. And to the D, we can see that this foreign body is placed exactly on the floor, just abutting the globe inferiorly. So then here we can note, on the CT scan showing of the axial view, here you can see that the foreign body is noted to just be short of the apex, and there were no cuts which would explain the avulsion of the optic nerve, because this was an image that was done elsewhere, and we also ended up picking up surgery in emergency at a setup elsewhere. So an immediate plan was made to retrieve the foreign body and with exploration and foreign body removal under general anesthesia. So I'll just play the video that we could capture. So with this imaging finding, we had assumed that there is a triangular foreign body on the floor, and obviously he had already come with a lacerated wound that was sutured elsewhere. So that would be our area of approach. So that laceration was, the sutured laceration was released, and the plan was to explore and identify if we could approach the foreign body. And with the imaging in hand, we had a rough idea that it would be more anteriorly placed. Even here, as we separate the sutures, we are able to see that there is a foreign body. You can see the edge of what was the foreign body already. So and this is an edited video, so it is slightly paced up, but you can see that on separating the laceration that was closed elsewhere, we're already able to see the edge, and slowly this foreign body was retrieved, and it seemed to be a very well-defined triangular one, and what was a very proper cut triangular piece of tile. So after that, the wound was re-explored, betadine wash was given, areas of any necrosis was identified, and then the wound was closed, this time with interrupted 6-0 vicryl. And finally, this was the retrieved foreign body showing its dimensions. It was almost about 5.5 millimeters in length with about 1.5 width. And finally, this was his image at post-operative 1 week evaluation, where you can see that the external wound is well opposed, and but he's developed a ptosis, which was almost near total ptosis. And on forceful retraction of the upper lid, you're able to see that the anterior segment is looking much quieter. The conjunctival chemosis and the congestion has reduced, and the pupil was reactive to light. And at this point, the visuality was 20/20 parts. And a worm's view, which is showing that there was no proptosis or anything that we could see in the post-operative evaluation.
Thank you, Dr. Priyanka, for that wonderful case presentation, which is really surprising to have such a large foreign body which was there lying, and the wound was also sutured primarily at an outside center, as you were telling us. So I think it's important to palpate the wound area before we close it, or we attempt to close it sometimes. And the neglected foreign bodies can also present as, discharging sinuses if we are not addressing them timely. And it was a good thing that it was not wooden, otherwise it would have been much more problematic. So I would like to ask Dr. Sonam for her comments in the case.
Priyanka, that's a very huge foreign body that you actually got it out there, and very well done. I think very nice in the nick of the time that you actually went in and intervened and got it out. What was the funnest finding at the time of presentation? Because I think the pupil was mid-dilated at that point of time, and then we see the pupil very nice and round towards the latter, a post-operative picture.
Yeah, actually, because of lack of proper documentation or photo documentation, so to say, I did not have all the pictures to show. But on table we did, I missed that even in the presentation. On table we did an indirect ophthalmic examination, fundus examination, and the disc was normal. There was no evidence of any pallor setting in or any such a thing. And also with a suspicion of, without knowing the nature of the foreign body, we also refrained from starting any steroids or anything immediately. So that was the only...
what was then your differential explanation for that? I just give a hint, vertically oval pupil. You said that the disc was normal. So what could be the differential, I think? Especially you can think of the high pressure, maybe the glaucoma. Because I think in ACG, if I correctly remember, the pupil is vertically oval. Yeah. I think that photo, it was showing a vertically oval pupil. So that was maybe the increased orbital pressure, which was causing the high IOP. Yeah.
And how was the extraocular motility post-operatively?
Yeah, post-operatively, it was within normal limits. Actually, pre-operatively, it was about -2 in all directions of gaze. And also, it was a little difficult to assess him on presentation because A, he was a little bit in altered sensorium, and B, it was a very tense globe. So he was also not very responsive to verbal commands. So that was the only thing that, so we do not have very good documentation of how his extraocular motility was pre-operatively, but yeah, post-op, it was fine.
What do you think would have been the cause of his ptosis post-op? How much was his infection?
Yeah, that was one thing that concerns me even now. It's quite strange that he would develop such a traumatic, a complete near total ptosis, especially knowing that it was not really at the apex. Initially,
by looking at the scan, it seems like there was some amount of apical crowding, which could have led to the ptosis. But maybe there was a pre-existing third nerve palsy. I mean, and an injury to the LPS, SR-LPS complex during the trauma itself, which may have caused this.
It could be
How much was
orbital compartment syndrome also. That
yeah,
maybe,
like a pseudo,
maybe,
yes.
Yeah. I think it should recover because the primary injury site was inferiorly, and later and all the foreign bodies. That may be an ischemic, ischemia, which has caused the compartment syndrome, which has caused ischemia, might recover. So I think the steroids must have been given post-op, or they were like intramethyl, or methyl prednisolone, or oral.
Yes, methyl prednisolone was given. Yeah. Yes, once the tile was, once we realized it was the tile, we immediately started him on IVMP, and he received about, I think, 3,500 milligrams in 3 days.
Okay, yeah. How old was the injury? I think I just maybe
it was just about a day old when he presented, and it was taken up the next day. So about 48 hours since the injury.
Okay. I think that's why there was lot of dissection, and because once the patient, they come later on, like they are missed like week or 2 weeks later, then everything starts to melt. There is a clear discharge, and it's very easy to dissect, just to suction around the foreign bodies.
It would have been difficult.
And it just easily comes out. So it's in an old injury, but it's I think it's easily removable. And wooden foreign bodies, can you just highlight the special care to be taken for wooden foreign bodies? This was a tile.
So if it was a wooden foreign body, one thing is we can assume that it would chip off. So retrieval of it should be extremely careful while retrieving a wooden foreign body. So we, as such, should avoid using tooth forceps to sort of clamp onto the wooden foreign body, because that can cause it to splinter out, and we might end up leaving a bit of the foreign body inside. That is one. And second, assuming that preoperatively that it is a foreign body which can be of a wooden type, then we would expect fungal infection to be high on our list. So any sort of a steroid treatment should be avoided unless confirmed. So that is also why we withheld using steroids in this case, and only after confirming the nature of the foreign body that he was started off on steroids.
I think more important, fungal will take time, but anaerobic infection is very fulminant with Clostridium, and also you will typically see gas in the CT, black around the foreign body or in the orbital tissue. And anaerobic infection, I think it's much more difficult, because it will cause necrotizing fasciitis, and it will it's difficult to manage also. So apart from, I think, routine broad spectrum for these anaerobic infections, it should be covered with metronidazole, and also especially the sinus, because the organism will enter from the sinuses also. And in these adults, anyways, like when we are having the orbital cellulitis, as such a primary orbital cellulitis, so anaerobic infection is difficult. It should be an important differential and to be kept in mind.
Right. Congrats, Priyanka, on managing such a bizarre case. Since this is a session on
very nice pie, very nice pie. I'm just imagining that who cut this pie and how it got into this organ.
It doesn't seem like it's chipped off from another bigger piece. It's so well defined and cut. It's like an intentional injury.
Horizontally, like it has entered horizontally. It should, like it's vertical, it should create a plane for itself. So it's difficult to imagine how it created horizontal through
just lodged.
Yeah.
It's like the patient tried to manage his own floor fracture or something.
Yeah, exactly. I was going to say that.
So while we're discussing trauma, something which is often asked in the oculoplasty groups and circles, and doubts that a lot of postgraduates tend to have, is about dog bites. So would you like to sort of give a small overview on that, Dr. Sonam? Just like a sort of capsule on dog bite management.
Sure, sure. So, well, dog bite injuries, as we know, quite common in India. So when you have, obviously, first as we get a patient in the ER or emergency, first thing is to obviously ask a proper detailed history. Okay, it is very important to know whether it's a street dog or it's a like pet dog. The dog has been vaccinated or not. If you do not know the history, please always consider that the dog has not been vaccinated. When you see the wound has to be properly analyzed. Okay, it has to be irrigated. You have to make sure that you have the anti-rabies immunoglobulin ready with you. Okay, because the wound has to be irrigated with that, and also towards the end, after you finish your reconstruction or suturing, you must inject periocularly. Also the same. It is very important to assess the child, obviously by the pediatrician, and start him on the anti-rabies vaccination according to the regime that they follow. And yeah, these are the basic things that we must do in a dog bite injury. Most often, you see the canaliculus is also involved in dog bite injuries, and that should be definitely repaired while you're actually doing the wound closure. So you have to export properly for that as well. Um, Am I forgetting anything, Dr. Saurabh? You can please add on to that. I think rabies shield is one that is available, and the dosage, you need 6 vials of rabies shield. So just getting 1 or 2 vials is not enough. Yeah, if I'm right. Yeah. I think you need to irrigate proper 7.5 ml or something based on the weight of the child.
Yeah, it has to infiltrate around that wound also.
Yeah.
Dog bites, like the typical, as Sonam said, they cause canalicular injury. They typically, like, they end up like biting hair around the face. When they bite, it's typical. It's unless proven, I think otherwise, dog bite definitely involves canaliculus, lower canaliculus, like a blouse hook injury we had. So, and the second thing is, I think in dog bite, especially, there is a tissue loss, some kind of a tissue loss which happens as compared to the primary sharp injury, penetrating injury. So that has to be taken care of. You may need, you may have lost some tissues or part of a canaliculus, or that has gone with the bite.
Often these kids also should be evaluated, because when they bite, it's the SO, which actually the superior oblique muscle, that actually
Yes.
can
Yeah, yeah.
get involved, and children might not really realize, but they might actually have some amount of diplopia. Then they come with a altered head posture. That is acquired Brown's, also something that must be taken into consideration. And I think the dosage is 20 international units per kg body weight of the immunoglobulin that should be given.
Right. And just a small thing about scarring. So, like in Priyanka's case, when they would have closed that eyelid laceration, later on you can expect quite a bit of scarring and induration to take place. So, Dr. Saurabh, do you use a lot of intra-lesional triamcinolone or 5-fluorouracil to sort of soften these scars? Or
No, not definitely not primarily. Once they start healing, like maybe 3 to 4 weeks later, in this case, like for lower lid, we can just evaluate with the just pull these lower lid skin up, whether it is freely mobile or not, or something fibrosis is happening. I think 3 to 4 weeks time after the primary repair, it should be evaluated for any scarring fibrosis. If any contracture is happening, then yeah, combination of tricot, triamcinolone, and this 5-fluorouracil can be injected, yeah, in the oculoris plane. Mostly, I think that will occur. The second thing, I think, will be more important, will be the septum, which is it's either stuck to the orbital rim, or if it has been sutured. So that will also cause the mid-lamellar contraction. So in that case, I think if the skin and all posterior part is fine, then you have to surgically dissect open up the septum and free the septum from where it is adhering to the bone, especially the bone, I think, rim, orbital rim.
right.
So these 5-fluorotricot uracils, they can be started at 3 to 4 weeks. they can be given weekly, or maybe in a 2 weeks time. They can be repeat, like we can give 1 or 2 or 3 injections. I think that should suffice, 1 or 2, 3 injections, depend upon the response and the fibrosis, amount of fibrosis which is happening.
I think Priyanka sutured that wound really very beautifully. And in cases, especially in Indian skins, you can never estimate how much amount of pigmentation is going to happen. So you can flatten out the scar, but you might not really be able to remove the pigmentation for the patient. So it's very important to assess first if they have any keloidal tendencies. Then, like Dr. Saurabh said, you can give 5 FUs, but you can give it as early as after 8 to 10 days of your suturing as well, if the patient's not going to come back to you and the patient has a scarring tendency. Also, something else that we start off Contractibex or silicone ointment to massage on the scar, soften the scar, and to flatten it out. And of lately, what we've got getting more into, because everybody wants to look good, is NDR lasers. So if there is a pigmentation, that works really well for the Indian skin. And 3 to 4 sittings, you can actually get rid of some pigmentation in the periocular area. Of course, doesn't work well for around the eyelids. But yeah, for the periocular scars, like the one that Priyanka showed in her case, and the patient is very conscious, he can go in for a nice NDR laser, 3 sittings. I think he should look good. Along with the peel, of course. I think if there is pigmentation, that is.
So, Dr. Saurabh, what about conjunctival DCRs? Like, are you doing much of those these days?
No, these days or past days, I have not done many. Even starting, yeah, we used to do during my senior residency when I was in Maulana Azad Medical College. So during and after fellowship, I think not much experience. I initially used to counsel for conjunctival DCR, but now I've almost stopped. I just tell them that there is nothing more than Botox, which we can, I think I can help.
Yeah, so I've been seeing the difference between the young and the old ophthalmologists, or rather oculoplasty surgeons. So I'll be like left and right counseling for Botox, but then the older generation always advises conjunctival DCR, and it seems like a real hassle to sort of manage them and then flush the tube and everything. So I was just wondering if you do it, since you're also around here.
I don't think it's worth the pain. I've removed. I think the only thing I've done is we've removed a lot of Jones tube, which have been just stuck there and doing no good to the patient. Like Botox works really well.
Yeah.
Since we have both LVPI people presenting, I think there was an idea about Botox versus just giving a plain injection into the lacrimal gland, which causes fibrosis and reduces the watering. So, I mean, it's not related to the topic, but for epiphora, Priyanka, have you guys got any pilot study, and how has that been?
Yeah, I remember Dr. Sonam. This one, I think with Dr. Nandini and Dr. Javed were working on it at one point. So I think we saw that till the time that I was finishing, we had about 2 patients, and for one patient, this needling was attempted actually for 2 of these patients, because that micro trauma itself induces fibrosis and maybe so they were getting into how to quantify the amount of improvement in this functional epiphora, but I've not seen more of that. I've seen Dr. Javed mostly do lacrimal, excision of the lacrimal gland more than injecting Botox for these patients who are really symptomatic and find the epiphora worrisome. But this microneedling and I've not yet seen the long-term improvement with that.
Thanks.
I think Dr. Rituja has rightly said that there is a paradigm shift. Even I have also not done conjunctival DCRs in the private practice. It's better to go for a lacrimal Botox. You can always counsel the patient that you might need it, a repeat injection 2 or 3 times, but lacrimal Botox is better for proximal canalicular blocks. And I think for distal canalicular blocks, lacrimal trephination with a stent can be, and mitomycin C injection along with that can really be helpful in many of the cases, avoiding the need of complex surgeries.
When we do the lateral Botox, what is your practice? Do you do it transcutaneous or transconjunctival?
I'm sorry. Did you ask me, Richa? I couldn't hear.
Yeah, like it was a general question to the panelists.
Like we prefer transconjunctival. Like just identify the palpebral lobe and
Yeah.
ask the patient to look down and inward, identify and inject. We use a 30 gauge needle, and it just about 1/4 to 2/3. I mean, 1/4 needle should just go inside the palpebral lobe and just inject out there. I prefer dilution of 0.1 is equal to 5 units, but I think a lot of others around prefer 0.1 equal to 2.5 units. So subjective. Dr. Saurabh, how do you prefer?
Transconjunctival only, yeah. And usually, like we give it for hemifacial spasm and blepharospasm. So we are, I am making like 2.5 units and 0.1 ml. So the thing is that it should be concentrated. We want to give the more units per volume. So it should be lesser volume so that it does not disperse into the surrounding tissues.
I think the only thing we have to be, sorry.
No, go ahead.
No, I think the only thing we have to be a little worried about is ptosis, especially in elderly patients.
Yeah.
So
Yeah, I think there are some who keep getting ptosis every time. It's like they're very sensitive or whatever. So they're like, ठीक है, एक करके फिर try करेंगे.
I think the LPS attracts the Botox there.
Yeah, or we don't know. Maybe they're developing more and more sensitivity. Who knows? We could probably go on and on chatting about trauma and all our other things, but we should try to end now. And before we close, I'd just like to let everyone know that the next session will be on pediatric ophthalmology and strabismus. So those who want to submit their abstracts, you could spread the word that they need to submit by 16th November for the next session. Yeah, so thank you, Dr. Saurabh, Dr. Sonam, Dr. Richa, Dr. Priyanka, and of course, Dr. Gunjan and Aarti and Divakant for helping in organizing this thing. And of course, Dr. Puneet, who got Dr. Saurabh to join us. Thank you to everyone for a great.
Where is he, Puneet? Puneet?
I think he got called in for some emergency.
Okay. Okay.
Yeah. So great to have everyone and young people managing such complex things. So nice to see all of that. And great to meet all of you.
Thank you. This was so much fun. Actually, I really enjoyed this. And thanks for such a lovely initiative. So thanks a lot.
Thank you.
Thank you. Thank you, everyone.
I think great case selection, great presentations also, and well documented and well managed. Difficult cases. It's not simple like canalicular. I think even the simple canalicular, when tear happens, it sometimes become very difficult to repair. So good cases, like definitely. And thank you, Rituja and Gunjan. Yeah, and Diva is here. I think he's turned off his video. He has just logged in and left.
He's the Zoom guy, so that's
He's the Zoom guy. Okay then. Yeah. Thank you everyone.
Thank you. Thanks a lot, everyone.
Thank you.
Thank you.
Thank
Good
you,
night.
Good night.
Bye.
Okay, bye. Okay.